Hello everyone and welcome to Drug Stories for this first episode about aspirin. A quick word about yours truly. My specialty is the research and development of medical products and technologies, from drugs to medical devices, diagnostics, vaccines, but also new stuff such as cell and gene therapies. I've been working in the medical industry for decades, and I have a master's degree in a specialty called pharmaceutical medicine, but I'm neither a pharmacist nor a doctor. So, here comes the disclaimer. This video is not a substitute for professional medical advice, diagnosis, or treatment. I am not qualified to provide medical advice. Always seek the advice of your doc or other qualified health provider with any question you may have regarding a medical condition. Never ignore professional medical advice or delay seeing your doc because of something you have seen in this video. And most important, do not self-medicate. Never self-medicate. I'm just a guy who loves telling stories about drugs. I am just a guy telling drug stories. And if you want to know why I chose that name, well, the answer lies in the acronym FDA, Food and Drug Administration. Drug. So, drug stories. So, in this first episode of Drug Stories, we are going to talk about aspirin. Why aspirin? Well, if I were to tell you about rock and roll stories, I would start with Elvis now, wouldn't I? Okay, more seriously. Why aspirin? 3 reasons. First, it's arguably the most famous, the most widely used, and the most studied drug in the history of medicine. Second, it's one of the drugs with penicillins that have saved and is saving the most lives in human history. And third, because the aspirin story is just epic. A 4 millennia saga with ancient wisdom, chemical innovation, corporate battles, global crises, scientific breakthroughs, and medical controversies that are ongoing to this very day. A bit like Elvis. This is not just the history of a pill, it's a reflection on the evolution of medicine itself. I've been thinking of launching this channel for a while, but now, especially post-COVID, I really sense massive interest in drug stories. That's why I will dive a little bit into science and cover some of the key aspects of drug discovery, the complexity of clinical practice, the critical importance of what we call benefit-risk assessment, and the ever-evolving nature of medical knowledge. And of course, as it's a series, everything you learn here will be useful for you when you watch next episodes. So let's go! The story of aspirin begins with willow trees. Long before the concepts of molecule, mechanism of action, or evidence-based medicine, ancient civilizations were using nature as their pharmacy. Try this. Sumerian clay tablets dating back 4,000 years contain references to willow being used against pain and fever. The Ebers Papyrus from ancient Egypt 3,500 years ago describes similar remedies. Our ancestors knew. These early uses were driven by observation and passed down through generations. Preparations from willow seemed to relieve suffering, even if the reason remained mysterious. The thread continues into the antiquity. Enter the Grand Master Hippocrates of Kos, the forefather of Western medicine, who gave his name to the oath taken by doctors today. Hippocrates specifically recommended preparations made from willow bark and willow leaves, particularly a tea brewed from willow leaves to reduce fever, but also to ease the pains of childbirth. No epidural at then, huh? So here we have Hippocrates, the top influencer of his era, the KOL. Well, his endorsement alone ensured the willow's continued use in Europe through ancient Rome and through the Middle Ages. But still, for centuries, willow remained a folk remedy. Fast forward to the 1700s, where a very curious guy came. An English clergyman, Reverend Edward Stone. He was living in Chipping Norton, southeast of Birmingham, halfway to London. A bit of a godforsaken area, if you ask me, known for its damp conditions. Picture you can see here was taken around mid-August. Aha. He was suffering from malaria and hoping for relief, he chewed willow bark and noted its bitter taste, a bit like cinchona, the Peruvian bark used to treat malaria by quinine. So he said, I have no primary source for that particular fact, but I'm pretty sure he said, And then just like that, he started a 5-year experiment on 50 parishioners, drying willow bark over a baker's oven, pulverizing it, and administering it for fevers. He observed its effect. What do you think? Reduced fever, reduced pain. Possibly the first clinical trial in history. So, in 1763, Stone sent his findings to the president of the Royal Society of London. This is a huge event. For the first time, Stone provided the first documented evidence of willow bark's efficacy in a Western scientific context. And you know what the Royal Society of London did? Classement vertical. Vertical classification, recycling Bing, dismissed willow as, and I quote, peasant medicine. Royals, peasants, this, that, you know. Anyway, the willow bark story tells us a fundamental truth in medicine's history. Empirical discovery often predates by centuries the scientific understanding of why a remedy works. Willow bark did relieve pain and fever. This observation was robust, repeatable, and clinically useful long before anyone could isolate its active component or explain its effects. And now comes the 19th century, the century of the Industrial Revolution, and with it, the birth of organic chemistry. With new techniques and new understanding of elements and compounds, chemists sought to unlock the secrets of medicinal plants in order to isolate the active principles responsible for their effects. And thanks to Stone's work and to its long history, willow bark was a prime target. Early attempts were made by Italian chemists Brugnatelli and Fontana around 1826, but they could only obtain impure substances. The first major breakthrough came in 1828. Johann Buchner, a professor of pharmacy at the University of Munich, for the first time isolated a small quantity of bitter yellow crystals from willow bark extract. He named this substance Salicin, derived from the Latin word salix, meaning, oh surprise, willow. But Buchner's salicin was still quite impure and obtained in very low yield. A year later, in 1829, French chemist Charles-Henri Leroux independently isolated salicin and improved the purification process, obtaining about 30 grams from 1.5 kilos of bark. This marked a critical step from a crude plant to a defined chemical entity, but one still difficult and expensive to produce in quantity. In 1838, Raffaele Piria, an Italian chemist working in Paris, hydrolyzed and oxidized salicin, and thus produced a simpler compound, salicylic acid, E07H6O3 for the chemists among you. Clinical experiments quickly showed that salicylic acid was a more effective pain and fever treatment than salicin itself. In drug development terms, we say that a compound is more potent than the other. But this increased potency came at a cost. Salicylic acid was very irritating to the stomach, causing severe gastric pain, nausea, and even bleeding, which greatly limited its clinical use. Another major obstacle was the reliance on willow bark, creating a bottleneck in the mass production of salicylic acid. The next advance came from synthetic chemistry. In 1859, Professor Hermann Kolbe, working at the University of Marburg in Germany, developed a commercially viable process to synthesize salicylic acid under heat and pressure from three simple raw materials. Number one, phenol, C6H5OH, derived from coal tar, which we had at hand in tons during the Industrial Revolution. Number two, sodium hydroxide, NaOH, aka lye or caustic soda. And number three, carbon dioxide, aka CO2. This was a monumental achievement. Think about it. For the first time, a compound identical to one found in nature could be manufactured synthetically on an industrial scale. This, as you can imagine, dramatically lowered the cost of salicylic acid and made it widely available. It didn't solve gastric toxicity though, huh? We'll come back to that. But, spoiler alert, there was no internet then. Even regular mail was an issue, travel was an issue. Scientists worked in isolation from one another, so you shouldn't be too surprised to learn that the molecule we now know as aspirin, acetylsalicylic acid or ASA, had already been synthesized before Kolbe's work. In 1853, Charles-Frédéric Gerhardt, a French chemist working in Strasbourg, very close to where I was born and raised, reacted acetyl chloride with sodium salicylate and produced a new compound which he named acetylsalicylic acid. But his preparation was impure and unstable, so he abandoned the work. Yet another French what-if moment, we kind of are a specialist of that. Regardless of that, and please remember this when you watch future drug stories, the story of salicylic acid reveals a fundamental challenge in drug development. Higher potency often comes at the cost of increased toxicity. We still needed to find a way to retain the benefits of salicylic acid while at the same time getting rid of its harshness. At that point of the story, I must tell you a bit about the late 19th century in medicine and society. This was a period of incredible change. While science was progressing, the therapy arsenal remained very limited. Pain, fever, rheumatic conditions were everywhere, and existing remedies were very risky. We had opium derivatives, which led to addiction, and other treatments involved toxic heavy metals. Think of cures like cocaine tooth drops, for instance. During this era, you also had a lot of patent medicines. Often weird mixes sold with exaggerated claims and aggressive marketing, preying on public desperation. Charlatanism, which I can tell you is never far away when it comes to people's health. Thus, there was a growing need for treatment that were genuinely effective, reliably dosed, not too bad in terms of taste, and somehow scientifically validated. It was in this environment that aspirin emerged, not just as a chemical discovery, but as a product of industrial chemistry and top-notch marketing. The company that brought aspirin to the world, you certainly know that, was Friedrich Bayer & Co., founded in 1863. It was initially a manufacturer of synthetic dyestuffs, and like other German chemical companies, Bayer saw the potential for applying its expertise to the field of pharmaceuticals. They established dedicated research laboratories staffed with skilled chemists and pharmacologists aiming to develop novel synthetic drugs. This is the story of aspirin's rediscovery. The story of Felix Hoffmann, a young chemist working in Bayer's lab in Elberfeld, now Wuppertal. The legend goes, Hoffmann was personally motivated to find better treatment for rheumatism because his father suffered from the condition and could not tolerate the standard remedy, sodium salicylate, due to its severe gastric side effects. Based on the abandoned work of Gerhardt, Hoffmann searched for a chemical modification of salicylic acid that would retain its efficacy while being gentler on the stomach. By the way, this is still our exact reasoning when primary objective in modern drug discovery. We'll see this time and again in future drug stories episodes. And bingo! On August 10, 1897, Hoffmann successfully synthesized a pure and stable form of ASA. His process yielded a much cleaner product than Gerhardt's. The newly synthesized ASA was passed to Bayer's pharmacology department, headed by Professor Heinrich Dreser, for preclinical evaluation. Initial tests in animals suggested that ASA possessed three properties. First, analgesic, that's pain relief. Second, antipyretic, fever reduction. And third, anti-inflammatory, all comparable to salicylic acid, but also appeared to cause much less gastric irritation. At first, Dreser was more enthusiastic about another compound synthesized around the same time, diacetylmorphine C21H23NO5, which Bayer would later market under the trade name heroin, the good old times. But the promising profile of ASA eventually won out. A catchy name was needed for the new drug. Bayer coined aspirin. The A came from acetyl. Spir, S-P-I-R, referred to Spirea ulmaria, the meadowsweet plant, another natural source of salicylate, and the source from which salicylic acid itself had first been isolated before Raffaele Piria's work with salicin. And in was a common suffix used for medications at the time. The name blended the chemical modification, A, with the natural origin Spir, creating an image of scientific modernity rooted in nature. It became a household name in a blink of an eye. Deutsche Masterclass, Deutsche Qualität. So we have a name. And now comes the marketing machine. Bayer launched aspirin in 1899 as a powder dispensed by pharmacists in individual doses. Recognizing the importance of medical acceptance, Bayer used a sophisticated marketing strategy. They distributed free samples directly to physicians across Germany and internationally, encouraging them to try the new drug and give feedback. Bayer also sponsored and published clinical studies highlighting aspirin's efficacy and improved tolerability compared to sodium salicylate. They emphasized its scientific basis, purity and reliability, key selling points in an area full of charlatans. They bashed their competition. Unlike morphine, it wasn't addictive. Unlike opium, it didn't cloud the mind. This targeted approach, educating and influencing the medical profession, proved super effective in building credibility and driving adoption. Bayer also moved quickly to protect its invention, securing trademark protection for the name aspirin in Germany and many other countries, including the United States. But they even did too well. The drug's phenomenal success ultimately killed his trademark exclusivity. Aspirin rapidly became synonymous with ASA itself, directly entering common language. By 1900, aspirin tablets and powders dominated medicine cabinets, but dosing remained erratic. At that time, Bayer was kind of solving this problem by instructing patients to take aspirin until ringing in the ears occurs. Now, this condition you certainly know about, called tinnitus, is still a recognized potential side effect of aspirin today. This already super-fast genericization process was further accelerated by World War I. When war started in 1914, Germany stopped aspirin exports to the Allies. Britain faced a dual crisis. On the one hand, a phenol shortage. You remember that phenol is one of aspirin's raw materials, but ironically, phenol was also vital for explosives. The pain triggers and the painkillers came from the same source. And on the other hand, the British public begging for pain relief. Same situation occurred in the US with an additional twist. The great Thomas Edison needed phenol for his phonograph records and had a huge plant for that purpose. And he was selling his surplus to the Germans, who in turn sold their surplus to American aspirin makers. What a mess. This crisis was solved only in 1917 when the USA entered the war. The US state seized Bayer's American subsidiary and assets, including the Aspirin trademark and the Bayer cross logo. Still used today, mind you. Only then could the Allies benefit from a stable phenol source, again to produce aspirin. And Edison stopped selling to the Germans. Attaboy. In 1918, following Germany's defeat, the Treaty of Versailles imposed heavy reparations. Among them, Bayer was forced to renounce many of its foreign assets, including patents and trademarks in countries like Britain, France, Russia, and the United States. Those were auctioned off in 1918 to a US company, Sterling Products Incorporated. But at the same time, Sterling, secretly partnered with Bayer's German operations to keep production alive. But regardless of World War I and its aftermath, the rise of Bayer aspirin is an example of pivotal shift in the pharmaceutical landscape. Think about it. It wasn't only Hoffmann's chemical synthesis that created a blockbuster. It was the integration of research with Hoffmann, preclinical testing with Dresser, strategic branding with the name aspirin, targeted professional marketing, and intellectual property management, all coordinated by a large industrial enterprise. This represented a move from individual discovery and small-scale preparation towards industrialized pharmaceutical development and commercialization as we know today. Anyway, while Bayer eventually regained rights to its name and logo in the US in 1994, the aspirin trademark itself remains generic in many key markets outside Germany. Eventually, this forced genericization, while being a commercial blow to Bayer, contributed to aspirin's worldwide availability and, most important, affordability, a term we will see many times in drug stories. And indeed, following its launch in 1899, aspirin conquered the world like almost no other medication before or since. Its rise was fueled by perceived efficacy, relative safety compared to alternatives, ease of use, and clever marketing, deeply embedding the drug with the 20th century life. Aspirin's acceptance by physicians and the public was really super fast. Initially sold as a powder until ringing in your ears occur, Bayer soon introduced standardized tablets, typically 500 milligrams. Didn't exist before and everybody followed. This innovation was crucial for mass adoption, giving convenient and accurate self-dosing, whereas powders needed to be measured and dissolved. Within a decade, aspirin was available in virtually all pharmacies across Europe, North America, and beyond. Doubling down on marketing, Bayer reached out to the remotest of places with trucks equipped with projectors and speakers to show films on aspirin. For many people, it was their first film ever. The drug's success came from being effective against a score of common ailments experienced by populations worldwide. Pain, headaches, toothaches, muscular aches, menstrual pain, fever from various causes, and inflammatory conditions like rheumatism and arthritis. Compared to the often ineffective or dangerous patent medicines and the harsh side effects of pure salicylic acid, aspirin offered tangible relief with what seemed at the time to be a much more favorable safety profile. It quickly became the hero remedy for everyday aches and pain. No wonder then why aspirin took center stage during one of the deadliest pandemics in human history, the Spanish flu, 1919. With no specific antiviral treatments available, physicians desperately needed ways to alleviate severe symptoms, particularly high fever and body aches. Aspirin became the cornerstone of symptomatic treatment, recommended by health authorities and administered widely, often in very high doses. Standard recommendations at the time could reach 8 to 10 grams a day, with some sources suggesting doses as high as 30 grams per day were used. The most desperate patients sometimes ingested handfuls of tablets, leading to toxic overdoses, and bizarre conspiracy theories that Germans had laced aspirin with the virus. Of course, we're wiser now, right? Aspirin's importance was even stronger during the Second World War. It was a standard component in soldiers' first aid kits on all sides for its ability to treat pain and fever in the field. By the mid-20th century, aspirin had become a cultural icon. It appeared in literature, in film, in advertisements. Its name had become shorthand for headache relief. "Do you have an aspirin?" became a common question, outlining the drug's complete integration into the daily lives and language of Western society. It represented modernity, scientific progress, and reliable relief in a convenient form. Comes the post-World War II era, a pharmaceutical boom. Advances in synthetic chemistry, in pharmacology, and, above all, the development of more rigorous clinical trial methods fueled an explosion of new drug discoveries in the 50s and 60s. Pharmaceutical companies invested heavily in research, seeking novel compounds with improved efficacy and, more importantly, better safety profiles than existing therapies. This period saw the emergence of very strong competitors, challenging aspirin's dominance by targeting its known weaknesses. Challenger 1, enter Paracetamol, acetaminophen for you guys in the US. Although it was first synthesized as early as 1878, and acetyl-para-aminophenol, known as paracetamol in most of the world and acetaminophen in the US and Japan, was introduced commercially in the 50s. McNeil Laboratories launched Tylenol elixir for children in the US in 1955, and Sterling Drug, the same Sterling, launched Panadol in the UK in 1956. Paracetamol's selling proposition was clear: pain relief and fever reduction effects comparable to aspirin without the risk of gastrointestinal irritation and bleeding. Yes, of course, it lacked aspirin's anti-inflammatory properties, but it was attractive especially for patients with sensitive stomach or peptic ulcers. Let's leave it at that on paracetamol. This is for a future episode of Drug Stories, because believe me, there is plenty to say and you're not ready. Challenger 2, enter Ibuprofen. This one emerged from the research lab of the Boots Pure Drug Company in Nottingham, UK, led by Dr. Stuart Adams. Legend has it, he tested the compound on his own hangover. So British. The Boots team synthesized ibuprofen in 1961. Launched initially as a prescription drug, Brufen, in the UK in 1969, ibuprofen offered a compelling combination of properties: effective analgesia, antipyresis, and significant anti-inflammatory activity, making it suitable for conditions like arthritis, as the ad here shows. What's more, at typical over-the-counter or OTC analgesic doses, which is 200 to 400 milligrams, ibuprofen was perceived as having a better gastrointestinal or GI safety profile than aspirin. I said GI. In our field, this acronym does not refer to the famous American soldier. It's gastrointestinal GI, better get used to it. But still, it was not entirely free from GI risks. Especially at higher doses or with long-term use, ibuprofen later became available OTC in many countries, UK 83, US 84, which made the competition with aspirin even wilder. The rise of these competitors was not only due to novelty or marketing, it was driven by a growing awareness and concern regarding aspirin's side effects, which led to a reassessment of its benefit-risk profile, particularly for everyday pain and fever. The core business of aspirin was threatened. So, what side effects are we talking about? Number 1, GI toxicity. The extent of aspirin-induced gastric problems, often mild, but which could lead to serious peptic ulcers and life-threatening GI bleeding, became increasingly documented and appreciated by the medical community and the public. Paracetamol offered a clear advantage for patients prioritizing gastric safety. Ibuprofen, while also carrying GI risks, was often better tolerated than aspirin at equivalent analgesic doses, providing a second alternative. Number 2, Reye's syndrome. What's that? Reye's syndrome was identified in the 70s and early 80s. It's a rare but devastating condition whose main symptoms are acute brain swelling and fatty liver degeneration. It was observed primarily in children and teenagers recovering from viral infections like influenza or chickenpox. Here it comes. Epidemiological studies established a strong association between aspirin use during these illnesses and the development of Reye's syndrome. No surprise then that this led health authorities worldwide to issue strong warnings against giving aspirin to children and adolescents with suspected viral infections. Warnings had to be printed on each and every box of aspirin, as you can see here. After that, paracetamol and ibuprofen became the preferred alternatives for children's fever and pain relief. I, for one, remember vividly as a kid my own switching from aspirin to paracetamol in France around this time. All right, let's climb up for a moment. The emergence of Reye's syndrome, decades after aspirin's introduction, shows how a drug's safety assessment is never set once and for all. Rare but serious adverse events, particularly those affecting specific subpopulations, such as children with viral illnesses, may only come to light after prolonged and widespread use. Hence, the critical importance of what we call pharmacovigilance, the continued monitoring of drugs after they reach the market, as our understanding of a drug's true benefit-risk profile can evolve significantly over time. This super fierce competition led to a significant erosion of aspirin's market share in the general pain and fever market, especially in pediatrics. Aspirin began to acquire an image, particularly among younger consumers and physicians, as an older drug with problematic side effects compared to the newer and safer alternatives. The threat was real. Was it the end? Thank you for listening. We'll see this in our next episode of Drug Stories. Stay tuned. Nah, let's continue. I'm hot now, people, not stopping. Come on, let's move on. The best is yet to come. Okay. So, competitors are killing the drug, fine. But apart from competition, there was another slight detail that was bugging people. Despite being one of the most widely used drugs for over 70 years, nobody knew how did aspirin actually work. Physicians and patients knew what it did. Relieved pain, reduced fever, fought inflammation. But aspirin's biological mechanism remained a mystery. Scientists had proposed various theories over time, but none really explained its effect. The lack of a clear mechanism of action, this is the term we use, and we will use in each and every drug story, mechanism of action, hindered further drug development and limited the exploration of aspirin's therapeutic potential. But the pivotal moment, the aha moment, the eureka moment arrived in 1971, my birth year. Courtesy of John Robert Vane and his colleagues at the Institute of Basic Medical Sciences, Royal College of Surgeons of England. Vane was investigating the role of prostaglandins, which were recently discovered compounds naturally secreted by the body and suspected of playing a role in inflammation. He used cutting-edge techniques involving perfused animal tissues like guinea pig lungs and rabbit spleens that released prostaglandins when stimulated. And then Vane made a groundbreaking observation. He found that aspirin strongly blocked, we say inhibited, the synthesis of these prostaglandins in those tissues. This discovery was the key. Prostaglandins are involved in many physiological and disease processes. They are generated at sites of injury or inflammation, causing blood vessel dilation, increased vascular permeability, and sensitization of nerve endings, thus explaining inflammation and pain. They also play a role in modulating the body's thermostat, which is in the brain, more precisely in the hypothalamus, thus explaining fever. Furthermore, some prostaglandins help protect the stomach lining from acid damage, while others, and specifically thromboxane A2, promote platelet aggregation, the crucial first step in blood clot formation. In short, Vane's discovery explained both aspirin's therapeutic benefits and its major side effects. By inhibiting the enzyme responsible for prostaglandin synthesis, an enzyme later identified as cyclooxygenase, COX, which we'll hear about in drug stories time and again, aspirin reduced the production of prostaglandins involved in inflammation, pain, and fever. At the same time, by inhibiting the production of protective prostaglandins in the gastric mucosa and of thromboxane A2 in platelets, aspirin caused its characteristic gastrointestinal toxicity and inhibited blood clotting. Vane not only solved the mechanism of action of a major drug class, but also shed light on the fundamental biological roles of prostaglandin. So, how did the world react to Vane's work? Let's say not too badly, as John Vane, together with two Swedish biochemists named Bergström and Samuelsson, was awarded the Nobel Prize in Physiology or Medicine in 1982. Vane's discovery did more than just explain the known. It fundamentally transformed how scientists and clinicians thought about aspirin. Here, people, we're going to go into a bit of science, so as Basher said in Ocean's 11, hang on to your knickers. Aspirin was no longer just an empirical remedy. It was a specific inhibitor of a key enzyme, cyclooxygenase COX, in a critical biochemical pathway. This immediately opened up new horizons. If aspirin inhibited prostaglandin synthesis, and if prostaglandins were involved in processes beyond pain and fever, could aspirin have other therapeutic effects previously unrecognized? The connection between prostaglandins, specifically thromboxane A2, and platelet aggregation was particularly exciting, suggesting a potential role for aspirin in preventing diseases caused by blood clots, such as heart attacks and strokes. That's 500 million people per year. See how a scientific discovery can revive even a very old drug? At a tough time for the drug, understanding how it worked transformed its narrative, paving the way for its second act as a major player in cardiovascular medicine. What's more, Vane's research is a superb example of the role of basic science in driving clinical innovation. His work was not initially aimed at finding a new use for aspirin, but at understanding fundamental physiological mechanisms involving prostaglandins. Yet, his curiosity-driven basic research provided the direct scientific rationale for exploring and ultimately proving aspirin's life-saving roles in preventing heart attacks and strokes. Let's rewind a bit. It is true that Vane's 1971 discovery provided the missing link, but hints about aspirin's potential effects on blood clotting and cardiovascular health had in fact surfaced earlier. In the 1950s, a California general practitioner named Lawrence L. Craven published several reports in medical journals. Based on his observations of increased bleeding in patients taking aspirin and his belief that blood clots caused heart attacks, he began recommending daily aspirin to his male patients to prevent myocardial infarction, MI. Then he reported, based on follow-up of his practice population, remarkably low rates of MI and stroke among those taking aspirin. However, Craven's studies were observational, with no control group, which means that by modern standards they were weak in terms of methodology. You've been through the COVID craze, so I assume you know what a control group is. Though his claims were largely dismissed or ignored by the medical establishment at the time, yet Vane's discovery changed everything, because it provided the biological plausibility for Craven's observation. The key was the understanding that platelets, the small blood cells responsible for initiating blood clots, produce a specific prostaglandin called thromboxane A2, TXA2, via use of the COX enzyme. We call this the COX enzyme pathway. What TXA2 does is that it stimulates platelet aggregation and vasoconstriction. So what happens if aspirin's in your bloodstream? It irreversibly blocks the production of TXA2 for the entire lifespan of the platelet, that is about 7 to 10 days. This reduction in TXA2 leads to decreased platelet stickiness and aggregation, which in turn limits the formation of blood clots that can block coronary and cerebral arteries. This clear, compelling mechanism provided the scientific basis for clinical investigation. From then on, many researchers launched clinical trials designed to test whether aspirin could prevent cardiovascular events. Logically, the initial large trials focused on secondary prevention, that is, preventing recurrent events in patients who had already experienced MI or stroke. These individuals were known to be at very high risk for future events, making it easier to detect a potential treatment benefit compared to studying lower risk populations. Significant early milestone occurred in 1974 with the publication of 2 randomized controlled trials, RCTs, back-to-back in the British Medical Journal. The first one, led by Peter Elwood and colleagues in South Wales, randomized over 1,200 men who had recently recovered from an MI to receive either 300 mg of aspirin daily or a placebo. After 1 year, there was a 25% reduction in total mortality in the aspirin group. But this difference did not reach statistical significance, possibly due to the trial limited size and duration. The second paper reported on a larger multi-center trial coordinated by the UK MRC Medical Research Council, involving over 1,600 men post-MI, comparing aspirin around 1.2 gram per day with placebo. This trial also failed to show a statistically significant reduction in ischemic heart disease mortality, although trends favored aspirin. Very simply put, ischemic means blood stopping due to a blood clot. At that point you may think, okay, sounds like 2 failed trials, what gives? Well, as a matter of fact, these trials were crucial. First, they demonstrated the feasibility of conducting large-scale placebo-controlled trials of aspirin for cardiovascular prevention. Second, they provided hints of benefit that strongly encouraged further research. Their publication triggered considerable debate and activity in the field. Thus, the late 70s and early 1980s saw a wave of larger trials on aspirin, and in particular the king of them all, ISIS-2, the second international study of infarct survival, a massive international trial published in 1988, which was an absolute game changer. It randomized over 17,000 patients with suspected acute MI to receive aspirin, 162.5 mg per day, a clot-busting drug called streptokinase, both, or a placebo. Together 4 groups, or 4 arms as we usually say. And take that. ISIS-2 demonstrated a highly significant reduction in 5-week vascular mortality with aspirin alone, 23% reduction, and an even greater benefit when combined with streptokinase, 42% reduction compared to placebo. A slam dunk of evidence for aspirin's benefit in acute heart attack. Okay, that's one really good trial, but there were plenty of others, some well executed, some flawed. Sometimes individual trials are inconclusive due to insufficient statistical power, but there's a way around this called meta-analysis. The ATC, Antiplatelet Trialists Collaboration, led by Richard Peto and colleagues at Oxford University, gathered and pooled data from virtually all relevant randomized trials of antiplatelet therapy, which were dominated by aspirin trials. That way they could analyze outcomes across hundreds of thousands of patients. Their results, published from the late 80s onwards, provided unbreakable, definitive proof. In patients with established vascular disease, so for secondary prevention, aspirin reduced the combined risk of non-fatal MI, non-fatal stroke, and vascular death by about 25%. The overwhelming evidence triggered action from regulatory bodies and medical organizations. The US FDA approved aspirin for reducing the risk of death and non-fatal stroke in patients with a previous stroke or TIA, transient ischemic attack, in 1980. For reducing the risk of MI in patients with unstable angina or previous MI in 1985, and for use during and after acute MI in 1988. Similar approvals followed in other countries. Major medical societies incorporated low-dose aspirin, typically 75 to 160 mg per day, into their daily clinical practice guidelines as standard of care for the secondary prevention of cardiovascular disease. The successful repurposing of aspirin for cardiovascular prevention represents a triumph of translational medicine, showcasing the synergy between basic science and clinical research. Vane's discovery provided the rationale, guiding the design of large-scale epidemiological studies. These trials in turn generated the robust clinical evidence necessary to convince regulatory agencies and change clinical practice worldwide. Aspirin's cardiovascular story, not just about the drug, it's a case study in how medical knowledge progresses. Good. With aspirin now firmly established as a drug of choice for secondary cardiovascular prevention, the next logical question came up. Could it also prevent a first heart attack or stroke in individual without known cardiovascular disease? Now that's another crazy story, far more complex and controversial, leading to decades of debate, shifting guidelines, and ultimately significant recalibration of aspirin's place in preventive medicine. Let's go! First, you have to understand that the threshold for recommending a drug for primary prevention is always higher than for secondary prevention. In secondary prevention, patients are already at high risk of future events, which increases the potential absolute benefit of treatment. In primary prevention, the target population is much broader, generally healthy individuals, whose absolute risk of having a cardiovascular event in the near future is rather low. Simply put, to justify giving a drug daily to millions of healthy people, the evidence must demonstrate not only a clear benefit, but also an exceptionally good benefit-risk ratio. The first major insights into aspirin for primary prevention came from two large trials in the late 80s, with conflicting results. The PHS, Physicians' Health Study. This US trial randomized over 22,000 healthy male physicians to aspirin, 325 mg every other day, or placebo. Published in 1989, it showed a statistically significant 44% reduction in the risk of a first myocardial infarction. However, it found no significant effect on stroke or cardiovascular death. The BDT, British Doctors Trial. This UK trial randomized over 5,000 healthy male doctors to aspirin, 500 mg daily, or avoidance of aspirin. Published in 1988, it found no significant reduction in MI, stroke, or cardiovascular death associated with aspirin use. As you can imagine, these contradictory findings generated huge confusion and debate. Despite the initial uncertainty, the dramatic myocardial infarction reduction seen in the PHS trial, on top of the established secondary prevention benefits, fueled enthusiasm for primary prevention aspirin. During the 90s and early 2000s, many clinical guidelines began recommending low-dose aspirin for individuals considered to be at moderately increased risk of cardiovascular disease, often based on risk scores incorporating factors like age, sex, smoking status, blood pressure, cholesterol levels, etc. The idea of a simple, cheap pill to prevent heart attacks gained widespread traction among both physicians and the public. However, regulatory bodies like the FDA remained more cautious, consistently focusing on the proven benefits in secondary prevention, while advising that the decision for primary prevention should be made on an individual basis in consultation with a healthcare provider. As more primary prevention trials were conducted over the years, including studies specifically in women, patients with hypertension or others, a clearer picture emerged. Here goes. While some trials showed modest reductions in ischemic events, aspirin consistently increased the risk of major bleeding events even at low doses, such as 75 to 100 milligrams per day. Most significant concerns were gastrointestinal bleeding from stomach ulcers and erosions, and less common but more devastating, bleeding within the skull. In the context of primary prevention, where the absolute risk of cardiovascular events is low, this unavoidable bleeding risk appeared larger, potentially offsetting any clot prevention benefit for many individuals. And that's what is a negative benefit-risk ratio, people. The debate reached a critical turning point very recently in 2018, 120 years after the drug's first launch, with the publication of 3 large and very well conducted prevention trials. Arrive! Aspirin to reduce risk of initial vascular events. 12,000 individuals at moderate cardiovascular risk and without diabetes to aspirin 100 mg a day or placebo. After a median follow-up of 5 years, no significant difference in the primary endpoint, which was a composite of cardiovascular death, MI, unstable angina, stroke, and TIA. However, aspirin significantly increased the risk of gastrointestinal bleeding. Ascend, a study of cardiovascular events in diabetes. Over 15,000 individuals with diabetes but no prior cardiovascular disease to aspirin 100 mg a day or placebo. Aspirin significantly reduced the risk of serious vascular events by 12%, but this benefit was annihilated by an also significant increase in major bleeding events by 29%. Aspirin in reducing events in the elderly. Over 19,000 generally healthy adults aged 65 years or older to aspirin 100 mg a day or placebo. After nearly 5 years, Aspirin found that aspirin did not reduce the risk of the primary endpoint, which was a composite of death, dementia, or persistent physical disability, did not significantly reduce cardiovascular events, but significantly increased the risk of major bleeding. On top of that, Aspirin also reported a small but statistically significant increase in all-cause mortality in the aspirin group, primarily driven by an increase in cancer-related death. This cancer finding was very surprising, contrasting with previous data, suggesting a potential cancer preventive effect for aspirin. So, what are the current clinical guidelines? The results of Arrive, Ascend, and Aspirin conducted in populations offer receiving better treatment for risk factors like hypertension and high cholesterol delivered a clear message. For broad primary prevention, particularly in older adults or those not at high cardiovascular risk, the benefits of aspirin do not outweigh the risks of bleeding. This led to significant revisions in guidelines. Organizations like the AHA, American Heart Association, or the American College of Cardiology, ACC, clearly scaled back their recommendations for primary prevention aspirin. And current guidance generally advises against routinely initiating low-dose aspirin for primary prevention in adults aged 60 or 70 or older. For adults aged 40 to 59, the decision is highly individualized. Aspirin might be considered only for those at sufficiently high cardiovascular disease risk and low bleeding risk at the same time, after a thorough clinician-patient discussion about potential benefits, harms, and patient preferences. The era of routine low-dose aspirin for primary prevention is largely over, replaced by a much more selective and cautious approach. Conclusion of all that. The 40-plus year saga of aspirin in primary prevention shows that a drug's benefit-risk balance is not an intrinsic property of the molecule itself, but instead is highly dependent on the specific indication, in our case primary versus secondary prevention, and the characteristics of the patient population, baseline cardiovascular risk, bleeding risk, age. What constitutes a net benefit for a high-risk post-MI patient may represent a net harm for a healthy older adult. From a public health perspective, such guideline reversals highlight the challenge of deprescribing, convincing millions of patients and their doctors to stop a medication that was promoted for heart health, especially one as familiar and inexpensive as aspirin, requires clear communication of risk information. It also underscores the difficulty of retracting established medical practices, even when new evidence does indeed require a change. So how about aspirin today? After more than 120 years, aspirin remains an essential medicine worldwide, but its role is more nuanced and even sometimes more controversial than ever. What's striking, though, is that its journey continues, with ongoing research exploring both established indications and new possibilities. So first, in terms of established uses, aspirin retains several well-established indications where its benefits are generally accepted to outweigh its risks for appropriate patients. Number 1, secondary prevention of cardiovascular events. Decades of trial evidence and meta-analyses confirm its efficacy in reducing recurrent thrombotic events. Number 2, acute treatment of cardiovascular events. Aspirin is crucial in the immediate management of acute coronary syndromes, including MI and acute ischemic stroke, where its rapid antiplatelet effect can limit clot progression and improve outcomes. Number 3, pain, fever, and inflammation. While often superseded by drugs like Ibuprofen and Paracetamol, as we saw, aspirin remains an effective option for analgesia, antipyresis, and particularly for certain inflammatory conditions like rheumatic fever or pericarditis. Second, there are contested and selective uses where aspirin's use is more selective or subject to ongoing debate. Number 1, primary cardiovascular prevention. As we saw earlier, routine use is no longer recommended for most adults. Number 2, preeclampsia prevention. Low-dose aspirin initiated between 12 and 16 weeks of gestation may be recommended for pregnant women identified as being at high risk for developing preeclampsia, which is a serious complication of pregnancy characterized by high blood pressure and organ damage. Some clinical trials and meta-analyses have shown that aspirin reduces the risk of preeclampsia in these high-risk women. However, recent trials showed more mixed results, which complicates OB/GYN guidelines. But third, what about yet another set of potential new uses. Perhaps the most fascinating aspect of aspirin today is the amount of ongoing research exploring potential new applications driven by known effects as well as possible other mechanisms that are not yet understood. Number one, cancer prevention and treatment. This is arguably the most active area of investigation. Some observational studies have suggested that regular aspirin use, particularly long-term, is associated with a reduced incidence and mortality for several cancers, in particular colorectal cancer, CRC. However, as shown in the mixed results of the disappeared trial of 2020, the evidence is complex. Benefits may depend on dose, duration, timing of initiation, and possibly genetic factors. And in any case, the bleeding risk remains a major concern, potentially offsetting any cancer prevention benefit, especially in average risk individuals. So how to decide? Simple. Same as before. Large ongoing trials are investigating as we speak whether adding aspirin to standard treatment improves outcomes for patients already diagnosed with cancer. This is called adjuvant therapy. As we said earlier, the surprise of increased cancer mortality in the Aspirin trial adds a significant layer of complexity and caution to this field. Number 2, VTE, venous thromboembolism. While anticoagulants are the standards for deep vein thrombosis and pulmonary embolism treatment and prevention, studies like Warfaser and Aspire have shown that aspirin significantly reduces the risk of VTE recurrence in patients who have completed an initial course of anticoagulation. Aspirin might offer a simpler alternative to long-term anticoagulation for extended prevention in some patients. Number 3, Alzheimer's disease and cognitive decline. As there might be an inflammatory component in Alzheimer's disease, aspirin was investigated for prevention. However, clinical trials, including a large cognitive sub-study of the Aspirin trial we mentioned earlier, have failed to show any benefit of aspirin in preventing cognitive decline or dementia. And finally, what about specific patient groups? Number 1, children and teenagers. Aspirin is generally contraindicated due to the risk of Reye syndrome associated with viral infections, except for rare specific indications like Kawasaki disease or certain rheumatologic conditions, and always under specialist supervision. Number 2, the elderly. Simply put, the benefit-risk ratio shifts significantly with age. The Aspirin trial demonstrated that for primary prevention in healthy adults above 70 years of age, the risks of bleeding and mortality outweighed potential cardiovascular benefits. Even for secondary prevention, while often still indicated, the higher baseline bleeding risk in older adults requires careful individual assessment by the practitioner and regular individual review. Number 3, comorbidities. You know that term now, don't you? The presence of other conditions strongly influences aspirin decisions. Patients with diabetes, for example, are at increased cardiovascular risk, but the Ascend trial showed that the bleeding risk largely offsets the vascular benefits for primary prevention. Another example, chronic kidney disease. It increases both thrombotic and bleeding risks, so it complicates decisions. Finally, research continues to explore whether aspirin possesses other biologically relevant actions beyond prostaglandin inhibition. So what can we draw today from all those data? If only one thing. The aspirin story underscores the central challenge of modern medicine today: personalization. More than a century of use, thousands of studies, and we're still trying to refine our ability to predict precisely which individuals will benefit from aspirins, for which indication, and at which dose, while minimizing the undeniable risk of harm, particularly bleeding. Universal recommendations are giving way to individual assessments, and we'll see this time and again in other drug stories. Okay, that was maybe a tough bit for you guys, huh? Sorry about that. Have a drink on me, will you? Okay, to conclude in just a few sentences. Aspirin is a paradox. It is one of the oldest, cheapest, and most familiar synthetic drugs, yet it continues to generate cutting-edge research, intense debate, and surprising findings. Its story is, in essence, the story of scientific discovery at the intersection of chemistry, biology, commerce, and history. But is the story over? Or will there be another chapter? I'll be very clear. The sheer volume of ongoing research on aspirin suggests the second option. Think about it. More than 50 aspirin clinical trials are ongoing at the date of publication of this video. Here's a few pending questions. Will the large adjuvant cancer trials finally provide definitive answers about its role in oncology, potentially leading to another major repurposing? Could novel formulations, perhaps targeting drug release or combined with protective agents, finally mitigate the bleeding risks? Will further exploration of non-COX effects reveal new therapeutic possibilities? And could the newest tools of personalized medicine, such as genomics, one day allow us to identify with precision exactly who should take aspirin, for what purpose, and for how long? That chapter of aspirin's life is still being written in laboratories and clinics around the world. So that's it for this first episode of Drug Stories. I hope you enjoyed the story of aspirin. Give me a thumbs up if you did. Tell me in the comments. And who knows, maybe you're a young student. Maybe you haven't chosen your specialty yet. And maybe now you think biology, maybe it's kind of fun. And if you do, just dive into it. I can tell you it's really fun. Above all, in the comments, tell me what drugs you'd like to hear about, to learn about in future episodes. Feel free to name any drug you want except Viagra, because Viagra is already on my list. I know you all want to know about Viagra. I know everything about Viagra except its effects on me. And the story of Viagra is really fascinating. But don't worry, I will give you a Drug Stories episode about Viagra. That's a promise. And again, remember, nothing in this video shall be viewed as medical advice. I am not qualified to give any medical advice, and you should always consult a doctor for any specific medical question, and you should never self-medicate. For those of you who are actually PharmDs, MDs, PhDs, I mean real scientists, real doctors, real pharmacists, this video and this channel are not intended to present comprehensive scientific reviews. There are peer-reviewed papers and books for that. Here in the process of making this video, I have sourced a lot of materials and then I have selected contents based on what I think is interesting for each and every one of you. So if something's missing, it's probably by choice. But if you think something essential is missing, tell me in the comments section. I will definitely read them and they will help me improve future episodes. Thank you so much for listening up to this point. Please subscribe to Drug Stories. If you can share this episode to your social networks, it will be fabulous. And don't forget to click on the little bell below the video to get immediate notifications of new episodes. Thanks again. See you very soon. And in the words of Jean in one of my favorite French movies of all time, Les Tontons Flingueurs, good health and happiness.